Welcome to Medscape. I'm your host, Dr. Andrew Wilner. Today, we are continuing our updates from the recent American Headache Society annual meeting. Dr. Jennifer Robblee, a headache specialist at Barrow Neurological Institute in Phoenix, Arizona, is going to share her presentation on defining refractory migraine. Welcome, Dr. Robley.
Thank you for having me. It's a pleasure to be here.
Dr. Robley, we've got words like incurable, uncontrolled, intractable, refractory, resistant. Why did you think and the committee decided that now is the time to refine migraine definitions?
As part of the American Headache Society, we've got our special interest group, and one of the groups is on refractory headache. And it's always a big part of conversation whenever we meet. So we're all very passionate about this group of patients, but we have very limited research on them. We don't really know who these patients are, why they don't respond to treatment, and we have no guidance on how we should treat them. We're also getting into the next generation of the ICHD-3, so the International Classification of Headache Disorders. So they're starting to work on the fourth version. And so now seemed like a good time. The other inspiration is that the European Headache Federation had just published their consensus on what they would recommend the definition of refractory migraine be. And in our special interest group, we thought it was a really great starting point, but there was a lot of questions about how you make this more globally accessible and some things that we thought needed further discussion. And so that was our inspiration.
I'm an epileptologist, and we've struggled with this with epilepsy
Yes,
patients. An
absolutely.
uncontrolled patient might simply be a patient who isn't adherent to their medications, while a refractory patient or an intractable patient presumably is someone who has actually taken the right medicines at the right doses and they don't work. So, one thing that's always kind of puzzled me, is there a difference between refractory and intractable?
So the terms have fluctuated in what gets used over the different definitions. There is definition starting back in about 2006, and I think they first used the term intractable, and then refractory got used, and they were sort of back and forth. We landed on using refractory, one, because it was what the European Headache Federation had used, and they actually came up with the terms resistant migraine as well as refractory migraine. So we liked that dichotomy of someone who's starting to not respond to treatment and then someone who's completely unresponsive to treatment. And there was a lot of discussion in our group about what the connotation of the term is, and one seemed a little bit more hopeful and one seems a little bit more just permanent state. And when you think about the patients who were refractory before we had our CGRP monoclonal antibodies released, there was a huge group of these patients who we would have considered as having refractory migraine. Then suddenly they get the CGRP treatments and suddenly they're responders. So just because a patient is currently refractory does not mean that there's not a treatment out there that exists for them. It just may not exist yet. And refractory seems to better fit that, where intractable sounds more like uncurable. And so that was one of the ways that we thought about it.
Okay, so which terms did you settle on?
So the final terms were resistant migraine and refractory migraine. Resistant migraine is someone who has not responded to at least three categories of migraine preventive treatments, while refractory migraine is you have not responded to any of the categories, evidence-based migraine preventives.
And then the probable comes in when they haven't had an opportunity to try everything because of insurance or some other thing. Is that right?
Correct. Yeah, so we use the term probable refractory migraine for someone who, say, they live in a low income nation where they simply don't have the CGRP medications, or perhaps they don't have access to onabotulinum toxin. Pediatric patients where they haven't been able to access some of these medications. Mind you, we just heard that praminezumab was approved for pediatrics, so maybe we'll start to see some better access there. Or someone who just simply cannot afford these medications, even if they do theoretically have access. The other reason it might get used is we specifically put for refractory migraine that at least four of the medications had to be due to true lack of efficacy. and both a CGRP medication as well as onabotulinum toxin had to be due to true lack of efficacy. And so that prevents it from being that these are just patients who have sensitivity to everything you give them. So you give them like a little quarter capsule and they get side effects, and you never know if they actually respond. Or someone who has a lot of contraindications to medications, you're just not able to try most of them. Those patients, we have no clue if they're refractory. They might be, but we don't know. So that would be another way that you might use probable. And we also said that you could be diagnosed with resistant migraine, and you could also have probable refractory migraine. So you're at least resistant. You could also be refractory, but we don't know.
That's very helpful. Now, where is this published so we can link to that?
Sure, it's encephalopathy.
Now, I have a question as a clinician. Is it really migraine if it never goes away?
Yeah, I think it's a great question. You're going to hear a huge volume of differences of opinions. My personal opinion is that migraine is a very heterogeneous disorder. And so, if we all had a similar disorder, you'd think we'd all respond to the same sorts of treatments. But clearly, there's a group of people where they are CGRP responders and a group of people who are not CGRP responders. So, for some people, CGRP is a driver of migraine. There's a whole group of people with refractory migraine where they have probably several other drivers. And are they all migraine? Theoretically, migraine, we call it a disease, but is it really a syndrome where there's a lot of things where migraine is the common endpoint presentation? Over time, as we learn the biology and better predict who's going to respond to what, I think we'll start to get better subcategories. The metaphor I often give is it's like saying someone has breast cancer. Breast cancer is a disease, but not all breast cancer is the same. You're going to look and check what the genetics are. You're going to say, are they ER positive, PR positive, HER2 positive? And that's going to tell you what their specific breast cancer is. I think migraine is basically that. We're going to eventually learn what type of migraine you have. And based on your type, then we will know what the treatment for your specific subtype is. So that's what I envision the future is. So is it all migraine? Yes. Do we know what that means? No.
Well, it sounds like one category of refractory migraine is CGRP responders.
Correct. At
Um,
least it was.
and what percentage would you say of people that come to you with refractory migraine and you give CGRP and all of a sudden their headaches are better? Is it 1%, 90%? Where would you say that sits?
I mean, if you were to just take the migraine population in general, a good rule is 50% have at least a 50% response. In a biased population like what I'd see, I mean, they're probably getting down more to 25%, and I'm just throwing that number out as a random. Let's say we cut that down by at least half. I find that I can sometimes predict who is more likely to respond. Someone who has a truly constant baseline headache that never goes away, I find they're much less likely to respond to treatment. Or if they do, it's a decrease in the severity. I'm not getting them down to a significant reduction in the overall frequency of headache, let alone migraine days. Those, they can come in and they truly say, I have 20 days of headache and I have 10 days that I'm completely headache free. That person, I'm going to find something that works for them. Someone who comes in and says, I have a constant baseline 5 and about 20 days a week, I hit, a 9. That person, I might get them better, but it's less likely.
Before we wrap up, how many trials of these things should physicians do before they refer to a headache specialist?
Yeah. So I think if you're trying to decide when to refer to neurology, a good rule is you've tried at least 2 preventives and 2 acute treatments. And a good trial of a preventive should be you've done at least 3 months and an appropriate dose. For things that are quarterly, so things like eptinezumab, onabotulinum toxin, those should be at least 3 rounds. And then for an acute treatment, if you've tried it 2, 3 times and you're just not responding at all, then you're unlikely to respond. But you want to make sure they've been counseled that the earlier you use it in the attack, the better it's going to work. If you've waited 5 hours to take it, I'm not surprised if it doesn't work. So you also want to make sure they've used it correctly. If you're a neurologist and you're trying to decide when should I send to a subspecialty clinic, that's going to come down to, I think, what your comfort level is. If you have a patient who you've diagnosed with refractory migraine, then I definitely think it's appropriate to send. Resistant migraine, that could also be appropriate depending on what your comfort level is. especially if you're not sure if you're missing a second diagnosis or perhaps you're missing an alternative diagnosis and you want us to do a deeper dive into that. I think those would all be reasons to send.
Very helpful, Dr. Robley. Anything else you would like to add?
I think the one thing that is important to know is a lot of these patients come to me after having seen other physicians, and they come to me kind of just expecting that I'll have nothing to offer them. They have often been told there's nothing left to try. They're very downtrodden about it. So if you are seeing these patients and you feel like you're at the end of your rope, just be careful with the language you use because a lot of these patients actually do give up, and luckily, some of them still end up with me. So I think it's really helpful to say, I'm not sure what else I can do, but there are lots of other things that we can do. And, I'd like to get you in for a second opinion. Or if you truly have, like some patients, I have literally tried everything. And as long as they're willing to keep trying, I keep doing those N of one trials. And then part of what I'm doing is say, I'm here, I support you, I validate what you're going through, and we'll keep our eye out because as new things come out, that may be the thing that you finally respond to. So I think giving them some hope because these patients are going to be at a higher risk of suicide. They have high rates of other pain, they have high rates of other chronic illness. So they are really struggling, truly disabled. And so being there for them, even if you can't make them better, is way more than what a lot of these patients actually end up receiving, unfortunately. So that would be my kind of ending plea to the community.
Dr. Jennifer Robley, thanks for bringing us all up to date on these new migraine definitions.
Thank you.
I'm Dr. Andrew Wilner, reporting for Medscape.